Globally, the number of people diagnosed with diabetes will, according to the World Health Organization, the WHO, and the International Diabetes Federation, increase from just over 400 million to 600 million by 2030. But who among us is at risk, and how will diabetes affect the next generations? The biggest increase will be in developing countries that are now growing economically, and some people and subpopulations may be at even higher risk due to additional risk factors such as low birth weight, single gene defects, or epigenetic factors, which means the biological mechanisms that switch genes on and off. But diabetes applies to every one of us who is overweight or obese and physically inactive. It is those who will be at high risk and will contribute to a large extent to the global diabetes burden in the future. As you can see from these two figures, based on studies from 200 countries and a total of 19.2 million participants, the number of obese men to the left and women to the right has increased ever since 1975 until 2014. If the curve continues its steep upward climb, roughly a fifth of men, 18%, and women, 21% worldwide, will be obese by 2025, and millions of these overweight and obese people will at some point develop diabetes. The rising curve is not the only serious change worth noting. While type 2 diabetes used to occur nearly entirely among adults, it is now occurring more and more often in children and adolescents too. Why is this happening, and how serious is this a problem? Professor Venkat Narayan might provide us with some answers to that. I've always seen diabetes as kind of an older person's disease, and seems to be changing now to a younger person's disease. Is that correct?
I mean, traditionally, when we spoke of young onset diabetes, people often considered that to be type 1, and you're correct, the type 2 form was largely considered to be adult onset. But increasingly, we are seeing the occurrence of type 2 diabetes also in young people. And yes, it is more common in older people, but its occurrence is also happening in younger people, and that is what is so disturbing.
Venkat, I'm interested to know why we're seeing more children getting diabetes than maybe half a century ago.
The first reports of youth-onset type 2 diabetes were from the Pima Indians in Arizona. And at that time in the 70s, this was a huge mystery. However, now we know that young-onset type 2 diabetes affects pretty much all ethnic groups, some more than the others. The reasons are quite complex, but the available data indicate that maternal factors such as mother's glucose during pregnancy, mother's weight and weight gain during pregnancy are powerful risk factors for young onset type 2 diabetes. In addition, childhood obesity is also a major risk factor for young onset type 2 diabetes, and the factors driving childhood obesity seem to be established within the first 5 years of life.
How serious is this problem?
Richard, we do not have a good grip on the numbers worldwide affected by young onset type 2 diabetes, but we know it is occurring more frequently in developing countries such as India, China, Sub-Saharan Africa, from the various reports that are coming out. We also know that when type 2 diabetes occurs in very young people, that the disease tends to be more severe with early onset of complications and often less than optimal response to treatment. Furthermore, when the disease strikes young people at the peak of their economic productivity, the toll on the economy of individuals, families, and societies is very large, and therefore it is an extremely serious problem, both in terms of health and economic consequences.
The prevalence of child obesity has in some regions and countries reached such heights that governments have implemented taxes on drinks containing added sugars. This is, for example, the case in Mexico, where more than 33% of children are either overweight or obese. In 2014, a so-called sugar-sweetened beverage tax was implemented by increasing the price of sugar-sweetened drinks with a minimum of 10% price increase. Early estimates associate the increased price with an 11.6% decrease in quantity consumed. As the cause of childhood obesity and thus of young onset type 2 diabetes are most often established long before school age, the best opportunity for intervention will probably be preschool or sooner, or maybe perhaps even in the womb, as Professor Venkat briefly mentioned, maybe because mothers-to-be are drinking sugar-sweetened beverages and eating fatty foods too. But is obesity really the major risk factor of getting diabetes in all regions of the world? No, it's not. If we look at this graph, it shows the relation between diabetes and obesity, and from the columns in the bottom, we can see that more than 50% of the causes of diabetes are not related to obesity. Let us ask Professor Ib Bukbia, who has for many years studied health issues, including diabetes, in low and middle income countries, to explain this further. Let's look at this graph, because it's very interesting that we think of obesity and diabetes correlating together, yet this clearly shows that that is not the case when it comes to the low income countries.
This is true. Most people think, including you, that obesity is the main driver of diabetes. And this is true in the Western world. However, in Southeast Asia and in Africa south of the Sahara, 70% or 50 to 70% of those who get diabetes are not fat. So the way of combating diabetes is not losing weight in these areas alone.
So what you're saying, as a young mother or a mother who can, at a reproductive age, from a low to middle income country, can actually have a malnutritioned baby, and still that could lead to them having diabetes?
Because the paradox at first sight is that if you have an overweight, fat mother, sorry for the expression, she will give rise to an overweight baby, which is prone to diabetes. However, if you have an underweight mother, she will give rise to an underweight baby, and strangely enough, this underweight baby and mother are at the same risk of developing diabetes as the overweight baby.
And how is that possible?
Yes, that's the big question, and it's probably a mechanism which starts early in life. If we start with the underweight mother, the underweight baby, not getting enough to eat in fetal life, the placenta may be having a problem. She may have malaria, she may be undernourished, whatever. And then what is the alternative for the baby? If it's not slowing down, it will be aborted, it will be born prematurely. So we have a mechanisms where you can put your foot on the brake, virtually speaking, in your metabolism in fetal life. So you're not aborted, you're not born with big malformations and so on. However, you are born small birth weight. You are born insulin resistant. And this means that this child, when it grows up and all of a sudden get a new affluent living condition, fast food, fizzy drinks and so on, sedentary life, if the child has been programmed to a harsh life, it can't tolerate to have the new lifestyle. And that's why it's going so fast, most likely, in the developing countries.
So, Ib, are you saying that we need to address, for instance, diabetes before the baby is born?
Yes, Exactly, that's my point.
Yet, as you say, the exposure of that child to different lifestyles will mean that they are programmed in a different way to deal with that.
Yeah. If you are programmed to a relatively limited or thrifty life, then if you are going into a more affluent life with unhealthy lifestyles, as we call it, even if it's very often living conditions, then you can't tolerate it. That means that those who are programmed as such will have earlier diabetes and more severe diabetes. And the tragedy is that in developing countries you already have limited resources for healthcare. So if you get diabetes when you're 30 years old and not when you're 60 years old, as is the case mostly in Western countries, then you have the burden of diabetes at a much earlier age when you are in the working age group. And that's why we'll have to start very early on with the mother.
As Professor Bukbia mentioned, both life and living conditions influences the risk of getting diabetes. So let's go back to Professor Venkat, who has lived the major part of his life in India. Can he give us some examples of the changes he has observed in daily life that could lead to an explanation of why younger people are still getting and will continue to get diabetes?
The change that countries like India have been going through during the last 20-25 years is astonishing and dramatic. On the one hand, that change is good because it's creating new prosperity, it's bringing people out of poverty, it's having improvements in terms of life expectancy. All of these things are good. But on the other hand, the change is extremely rapid. Urbanization is very unplanned. For example, the big changes that I'm noticing is you hardly see any bicycles on the road anymore. 25-30 years ago, lots of people cycled on the roads, lots of people walked on the roads. Now, clearly, people, even to walk 100 meters, would use mechanized transportation. That also introduces traffic jams, congestions, making lifestyles very difficult. The second big change you notice is a gross change in food habits. Gone are the days where most of cooking used to be done at home. Now people generally eat outside or buy manufactured foods, a lot of which are refined processed carbohydrates, very high in fat. And you go to a wedding, for example, there's considerable food diversity, all kinds of different foods being served, large buffets. So consumption of food and changes in food pattern is very evident. In parallel, the consumption of fresh fruits and vegetables has been going down or does not exist at all in many parts of India. In addition, there is considerable urban stress, considerable traffic pollution, and several other factors. But I want to mention that urbanization is a fact. It's going to happen throughout the world. We can't stop it. But what we can do, really, is smart urbanization. When you look across the world, there are many examples of good cities that have developed in a planned manner, and those cities can be extremely healthy. For example, in the United States, a poor person living in New York is healthier than a poor person living in certain rural parts of the country. It's because the cities have invested in infrastructure, are turning more energy efficient, are making walking and bicycling very friendly, such as your own Copenhagen. So I think we need to think of healthy urbanization as a very important strategy. The other change that I'm noticing is when you walk into diabetes clinics, you see a lot of obese people with diabetes, but you also see a lot of thin people with type 2 diabetes. It's that combination, that dual burden that needs to be resolved.
Venkat, are people aware that they have it in low and middle income countries? I mean, how aware are they of diabetes?
Worldwide, about 50% of diabetes still remains undetected. That can be as low as 25 to 30% in high-income countries, and it can be as high as 80% in sub-Saharan Africa. But worldwide, there's clearly a rising awareness that diabetes is spreading. Talking from India, for example, I think the fact that India is one of the capitals of diabetes is very well known and regarded. But what is not clear to the population at large is that type 2 diabetes can also affect thin people and young people, and it might have other reasons in addition to the ones that we know.
So what should people be aware of if, as you're saying, this is targeting different parts of the population?
I mean, frankly, like I said, type 2 diabetes can go symptomless for a very long time. So I suppose we need to raise the level of suspicion. If somebody, for example, has a very strong family history, or somebody has gained a lot of weight recently, or changed their lifestyle, or has other risk factors, or somebody has become obese, for example, in such people, testing for diabetes and pre-diabetes is important. But I want to once again highlight the fact that obesity per se may not be enough. There might be a lot of thin people who apparently look normal who are developing type 2 diabetes. So the risk really is about family history, awareness of risk in the community, etc.
Venkat, when you go to your doctors, you go and get a diabetes test, is that right? Do you say, can I get a diabetes test?
Right.
Is it that simple?
I wish it were. I mean, in a sense it is. But I think before we go to that, we probably need a questionnaire that the doctors can implement that screens people that are likely to require the test, number one. And second, doing the test is only a beginning. We need to ensure that the system has the capacity to deliver the interventions, whether it's lifestyle interventions to prevent diabetes or interventions to prevent diabetes complications. I think all of that is important. Simply testing somebody and not having the capacity to look after them beyond that would not be ethical. And this is why we need to view screening for type 2 diabetes in the context of good health systems that can both deliver prevention and high quality care at very low cost and convenience.
On top of the rising occurrence of diabetes in the low-income countries, there seems to be further implications regarding linkage between communicable and non-communicable diseases, like, for example, tuberculosis and HIV. How does it become even more complicated for you if you already have a disease and then you have diabetes on top?
Well, we now know that if these two different, in principle very different diseases, an infectious disease like tuberculosis and a non-infectious disease like diabetes, and they meet, something very unhealthy happens. The one is making the other worse. So if you are having a dormant tuberculosis bacterium in your lung, as 1/4 of the world's population have without being sick from it, then if you get diabetes, the risk of coming sick from tuberculosis to have what we call open lung tuberculosis will be 3 times higher. That's something we knew already from 2 related diseases like HIV, which is an infectious disease weakening your immune system, and tuberculosis, where we know that the risk of developing tuberculosis is 4 to 8 times higher if you get HIV infected. But now we also know that the same happens when you are having diabetes. And as we have mentioned before, there's an epidemic of diabetes in low-income countries, and that means that, for instance, in India, 20% of all tuberculosis is now related to diabetes, not to HIV. We had a recent study in Pakistan, 40% of all newly diagnosed TB patients have diabetes, or at least elevated levels of blood glucose. And half of these didn't know it. So you could also turn it around and say it's positive. Now you can discover diabetes earlier on when you present with your TB, and vice versa. And we know very well the longer you wait to having your diabetes diagnosed, the more complications you get. So it's a golden opportunity if you screen for diabetes in a TB department, which is not exactly the first thing a TB doctor is thinking of.
So how big is this a problem globally for infectious diseases and diabetes, or is it just in specific parts of the world?
It's not a problem in my home country, except in some immigrant groups, Pakistani, Turkish and so on, because they have still higher levels of tuberculosis, whether it's dormant or whether it's active. But what about the rest of the world, where almost everyone has tuberculosis dormant in their lungs, and now you are going from 5% having diabetes to 10%, to having 15%, to having 20%, as is the case in some of the big cities in Southeast Asia. So in India, it's considered that maybe 20% of all TB nowadays is related to diabetes. In Africa, it's much more related to HIV. However, since Africa is the continent where diabetes is going to double the fastest, it will become a big problem in Africa very soon.